Hi, my name is Brianna Ferrantino. So, my patient today was a 33-year-old female who came in with a complaint of left posterior thigh pain that occurred 3 days ago when she was playing in a soccer game. And she said that during the time of injury, she experienced a sharp pain in the back of her leg, and after that, she was unable to continue playing soccer and she had to stop playing. And since then, she's been unable to run, and she's also had pain during walking. She said that her pain during walking has been a 5 out of 10, and her pain at rest has been a 2 out of 10. Um, she said that she had no previous history of injury in that area, and she reported no significant past medical history, but she did say that she had had a few um, ankle sprains in her left ankle when she was younger. She said that she has been playing soccer and running since high school, and she said that she currently works as a nurse, and so her goals with treatment are to get back to walking, working as a nurse without any pain, and also being able to play soccer. So during the exam, I noticed that she had an antalgic gait because she was spending a less amount of time on her left leg. And I also noticed that she had strong but painful resisted knee flexion when she was lying on her stomach during the exam. And I also did some palpation and noticed that she had tenderness and some inflammation on the lateral side of her posterior thigh. So from there, I decided to test MMT of the different hamstring muscles. So for biceps femoris, she had a 4 out of 5 strength on her left, which caused her pain when she did this as well, but her right was a 5 out of 5. And then with semimembranosus and semitendinosus, she had a 4 out of 5 strength on her left, but it didn't create or reproduce the pain that she came in complaining of. And then on her right, she was a 5 out of 5 for that strength. I then looked at her hamstring length with the 90-90 test and found that on the left she was negative 60 degrees and she had to stop because of pain, and on the right she was negative 10 degrees. And then I also looked at some contributing factors to see if there was any problems at her hip that could be causing or could have resulted in this injury, and I found that her hip abductors had a strength of 4 out of 5 on the left and 5 out of 5 on the right, and then her hip extensors also had a 4 out of 5 strength on the left and a 5 out of 5 on the right. So with all of this, I determined that the patient had an ICF-based diagnosis of hip pain and muscle power deficits, specifically an ICD diagnosis of a first-degree hamstring strain. And so for treatment, the priority is really going to be to control the pain and inflammation that this patient's experiencing, because we want to prevent any further damage to the hamstring muscle, like any further scarring or anything like that. We also want to be able to allow the patient to walk without an antalgic gait to decrease any stress to surrounding joints. And we also want to decrease pain so that she is better able to tolerate the treatment that we're providing and she can have more beneficial sessions. Our second priority for treatment could be to focus on the hamstring length and strength deficits and really trying to increase the length of these muscles and strengthen them, as well as addressing the weakness in the hip muscles. And these impairments will be important to address so that she can get back to walking and also playing soccer and hopefully preventing any further injuries in the future. So to start with interventions, we can begin with price and early motion. So we can provide education to the patient about using crutches so that she is no longer walking with an antalgic gait. We can also educate on the importance of resting, resting or restricted activity to try to avoid any pain-provoking activities that could make the injury worse. We also want her to be icing about 15-20 minutes 3 times a day until that inflammation starts to go down. And while she's doing that, it can also be beneficial for her to try to elevate her leg. And then in addition to that, she can also decide to use either an elastic wrap or elastic bandage to help add compression throughout the day. So that's important to educate her on for her own care. And then for manual therapy, we can work on DFM to the biceps femoris, and we can follow that with either some electrical stim or some active range of motion depending on the patient's tolerance. And then we can also focus on some early motion by doing active knee flexion and extension range of motion in a pain-free range. And then we can also do submaximal isometric contractions for the knee flexors, again in a pain-free range. And after doing those treatments, we'll want to give the patient ice so that we can control any inflammation that we cause during treatment, as well as control any inflammation that she already has. And so once we get the pain and inflammation down, then we can start to work on the second priority for treatment, which would be stretching the hamstrings, strengthening the hamstrings, and also strengthening the hip abductors and hip extensors to again try to improve her overall strength so that she can progress back to the functional activities of walking and being able to work as a nurse, and then eventually progressing to being able to play soccer again. So that was my patient. Thank you.